teeth. Adult have generally should have 32. Depends on um, how you look after your teeth. Generally 32, 8 in each quadrant. We talk about the upper left, upper right, lower left, and lower right. There are few ways of annotating these, and I think the simplest way is to count as in from the start. The central incisor is 1, and the upper third molar would be the number 8. If you use a quadrant fashion of writing it, then you can say upper left 8 or upper left 4. And if you can see my mouse starting from the center, 1, 2, 3, 4, 5, 6, 7, 8. For kids, it is A, B, C, D, E. They've got 5 teeth in the top quadrant on either side and 5 at the bottom. So it would be an upper right A as their central incisor on the right. The insides of the tooth, there's a cartoon here. The hardest part of the body is enamel, which provides protection, function, and the insides is a neurovascular element, which is called the pulp. If anybody's had a root canal at the dentist, that's the bit that is stripped out, and a filling is done to seal the insides of the teeth to prevent infection egressing or ingressing into the tooth and bone. Most common dental infection happens because people, if the teeth is neglected or there is trauma to the tooth, bugs and infection goes into this neurovascular space, and that then transgresses into the jaw. And that could be an acute pulpitis if the infection stays within the pulp, or can go into the bone, leading to a periapical, as in towards the apex of the tooth, periapical infection, or then further on, infection going into the bone. Um, Nature finds a way of draining pus, and sometimes these things then progress and go into the bone, through the bone into the soft tissues, either into the mouth or into the neck. And I'll touch on dentofacial infections a bit later. So that's the simple stuff here. Um, all of us do a head and neck examination, but if you are concerned, and I think a part of the head and neck examination should be a thorough oral examination. It's always good to have a systematic way of looking at it. And this is just a cartoon of how to start with the top jaw, start with the hard palate, the oropharynx, the tongue on the ventral surface, floor of mouth. Use a swab to hold the tongue to the left and right. Have a good look at the lateral border of the tongue. And sometimes certain mucosal lesions appear more obvious when the surface of the tongue is dried or the buccal mucosa is dried. So look at it with the saliva and wetness present, and if you're not sure, just dab it dry as well, as certain subtle mucosal changes will become more evident. Same with the top jaw. Um, that's just a cartoon. And part of the head and neck examination, apart from looking into the mouth, would be the ENT examination, feeling the jaws for any obvious abnormality, and completing with a thorough examination of the neck and the skin. So we have just put some pictures. So Chantel, maybe worthwhile, you could unmute people, as in would be happy for people to jump in and shout out quick answers here. So these are all referrals who have been sent to me as 2-week waits in the last couple of years. So this is from thought as suspicious.
So I think it might be best if we use the chat function just so that we don't get
No
the background
problems.
noise
That's
if you're
okay.
in sort of hospital settings and so on.
So that's okay. So these are some hard lumps. 2 pictures on the left show on the palate. The one on the bottom right is on the buccal aspect of the maxilla, and this is the alveolar bone, where alveolar as in the bone that holds the jaw teeth, and it's again 2 hard lumps on the inner aspect of the lower jaw. These are very common lesions, quite often being referred by dentists or GPs or colleagues as 2-week wait referrals. So anybody, feel free to just send a chat text to Chantel and see if you've got the answer correct.
Yeah. So we've got a few people coming in suggesting torus pilatus.
Yep, torus palatinus. And this is also like a torus. These are all benign osteomas. If it sits on the palate, torus palatinus. If it is buccal or on the label, this is just a label osteoma. And these are torus mandibularis. Torus from taurus, as in the bull, toros, and bull's horn. Quite an unfortunate association, but does the job. So further, some more two-week referrals here. Very common referral for lumps on the back of the tongue on the lateral aspect, suspicious of cancer. You look at these patients, have a good feel. There is no induration, looks symmetrical on both sides, can sometimes go up with upper respiratory tract infections. And again, feel free to text Chantel and take a guess on this one.
No one's been forthcoming, so perhaps you can enlighten us.
Okay, so these are just the filiform papillae on the lateral aspect of the tongue, also called you've got lingular tonsillar tissues in these. These are like leaf-like folds on the back of the tongue, which is common, and you can have tonsillar tissue within it as lingual tonsils. This is a well-circumscribed ulcer with a round whitish margin to it, minimal induration underneath, and generally can be associated with trauma. So that is, again, just a traumatic ulcer. Look for the cause. Usually there's a sharp tooth which the patient's biting on, and that tooth needs to be relieved. Some reassurance and warm salty mouthwash, and then review the patient definitely in a few weeks' time. If it hasn't gone, then consider biopsy, but most of these resolve with time. Soft, firm lump on the inner aspect of the lip. This patient has two, one on either side, usually around the canine teeth, might have history of trauma or could be spontaneous as well. Any takers for any of the pictures, Chantel, let me know. Maybe I'll go on to the next one. Young patient with a soft cystic lump on the lower lip, fluctuates with time, and when it's really bad, gets a blue dome to it. And any takers for either of these so far?
So you've got a suggestion of a mucus retention cyst.
Yep, so that's this one, which is also colloquially called a mucocele, mucus retention cyst, or can be post-traumatic as in a mucus extravasation cyst. So minor salivary gland origin, you get some trauma to that area, and the saliva then leaks under the surface or the mucosa and then forms a bubble. If this is persistent, doesn't go away, then best is to cut out the cyst, but with the associated minor salivary gland. That's the treatment for these. This one is a fibroepithelial polyp, so benign condition. It is secondary usually to trauma or could be just a polypoid growth. So again, simple excision with minimal margins is all you need for this. Most of the time you can do this under local anesthesia. Not uncommon inside the cheek lining or buccal mucosa at the level of the teeth plane. Okay, so I'm going on to the last one here. So this is usually a rhomboid appearing area of depapillation on the dorsum of the tongue. Can be tender, can be sensitive to hot and cold food or spicy or citric food, and patients might have a background history of diabetes or could be in a healthy person as well. Any takers?
Is this geographic tongue?
No, this could be, but this is more a descriptive term. It's called median rhomboid glossitis. Median bang in the center, rhomboid diamond-shaped glossitis, just inflammation and depapillation. You can do some candidal swabs for this. Occasionally there is candida superinfection in that area, but if that is the case, then give them some antifungal treatment. But otherwise, just reassurance. Discharge. Geographic tongue chanter, like you mentioned, could be again areas of depapillation which can change on the surface of the tongue. So one day it could be like this, a few weeks later it could be another area here, or could be like islands or continents on a world map, hence the description of geographic tongue. Historically had a more unfortunate name called scrotal tongue. So this is a more mucocutaneous condition. This is different types of oral lichen planus. Most common is a faint lace-like, gossamer-like changes on the buccal mucosa or the lip or the tongue. This is slightly more prominent, more erosive areas here, something like this. I would definitely biopsy. And about 40% of patients can have cutaneous lesions on the back of the hand. These just look like violaceous papule, which are quite itchy, like can be seen in this patient's hand here and on the palm as well. So ask for history of other skin conditions that the patient has had. These are pre-malignant with a small malignant potential of about 1 to 2% annually. It's mainly the erosive ones, and also patients with less risk factors um, can strangely have a higher preponderance for malignant transformation. But if the lesions look red and angry, biopsy them, keep an eye on them. Management for the simple ones would be, if they're asymptomatic, do a biopsy to prove the diagnosis. And then for symptomatic patients, you can use topical mouthwashes such as benzidamine or Diflam. These are just a local anesthetic mouthwash for symptom relief. You can use topical steroid like betamethasone, which can be applied over the surface of this. But this is not the cure, it's symptomatic management. These are, as you can see, different varieties of vascular lesions in and around the mouth. Um, if they are low flow, then it's not really worth doing anything about it. If they are very high flow, then definitely worth investigating. Could be an isolated vascular lesion like here and here. These are both low flow. So was this, but you can have large venous malformations or large capillary hemangiomas, port wine stain. Um, some of these can have intracranial extension, some of these can have cervical extension. So it's worth investigating. Investigations of choice would be a ultrasound with flow assessment and MRI scans. There are several ways of managing it. Simple isolated ones like this, and this. If they are symptomatic, patients keep biting it. Or like this pleasant 82-year-old patient of mine who kept getting picked on by her grandchild. Then you can do a simple surgical excision of these, cut them out. But you can use intralesional agents and manage these by the interventional radiology aspect as well. Going on to certain more aggressive lesions, I'm happy for people to text back and guess, makes it more interesting, or I can just talk you through it.
I'll let you know if we have any takers.
Okay. So that's a verrucous lesion. That is not a verrucous carcinoma. That's a verrucous hyperplasia. That's Asian person with a history of palm chewing. The areca nut in the palm sits in the buccal cavity and causes scarring at the submucous level. This is called oral submucous fibrosis. It is not just restricted to the buccal mucosa. That's where it usually starts, but you can then progress to the back wall of the pharynx, lateral wall of the oropharynx, lips, and then causes progressive trismus as the soft pliability of the cheek lining reduces. So they get progressive trismus. This is pre-malignant and up to, depends on which part of the world you work, number of patients you see with this. But if you're working in a very, in a population where there is quite aggressive use of pan and topical tobacco and areca nut, I would say up to 40% pre-malignant. This is chronic hyperplastic candidosis, always difficult to diagnose by the pathologist sometimes. If you see candidal hyphae on the pathology, on the biopsy, then definitely treat them. I usually give them 2 weeks course of fluconazole and then, if needed, repeat a biopsy. And if it doesn't go away, definitely repeat a biopsy. It's not uncommon for dysplasia to hide in these specimens, and sometimes even obvious malignancy. And these are also pre-malignant. Similar kind of picture with a more aggressive hyperplastic anidosis. These looks like cancer unless proven otherwise. Um, that at the back there is a vesiculobullous lesion, as in these vesicles, if you have a vesicle on the surface of the skin, they can last for a bit, but inside the mouth, they burst very quickly. And therefore, the patient might just present to you with a history of a nasty sore ulcer, but this is pemphigus. So these need to be managed in association with the dermatologist, or dermatologist, depends on how badly they are spread. But acute management would be pain relief, symptomatic relief, biopsy, which includes histopathology and immunofluorescence, and then further management with topical or systemic steroids if needed. These are the easy ones. This is what I do for a living. This is my day job. So these are all cancers. That's a very young patient. She is in her early 30s with a nasty, rapidly progressing tongue SCC. Sometimes these subtle gingival growths can be difficult to diagnose, and it's not uncommon for people to get some loosening of teeth, and the dentist then progressively started to take teeth out, and then you get a referral saying non-healing socket. So that's polymorphous verrucous leukoplakia, and with SCC in it. That's a minor salivary gland adenocystic carcinoma in a young lady in her early 30s on the left palate, sitting on top of the opening of the greater palatine foramen with perineural spread tracking up towards the skull base. She had a partial maxillectomy with the nerve being chased up to the skull base. That's a standard big tongue cancer. Again, an erythroleukoplakia on the clinical examination intraorally, but on radiograph, that there's a big moth-eaten appearance of the jaw, of the mandible, and the posterior maxilla. So SCC, but quite considering the radiograph, this was still a bit subtle on the surface. So multiple biopsies from this to prove it's an SCC. And then she had resection of the upper jaw, back of the upper jaw, and the mandible, and reconstruction with the scapula. So useful slide. Leukoplakia just means a white patch that you can't scrape away, and you can't really put any other diagnosis to it. It's about 5% transformation rate. This is from Mark Shifter from Sydney, an oral medicine consultant. And also worry about these non-smokers, idiopathic leukoplakia. They have a higher cancer risk. Females, higher cancer risk. Floor of mouth and lateral tongue is the most common site, and anything that's over 2 centimeter size. If it is very uniform, it's less likely to be dangerous if it looks like the Canadian flag white with red bits in it, or very red, broken down, ulcerated with white bits in it. These erythroleukoplakia or leukoerythroplakia have a higher risk of cancer, and they need surveillance. So the other things you might see in our shared field would be jaw swellings. It could be either cystic or solid. The WHO classification for jaw cyst and tumors was updated a couple of years ago. The most common ones in practice would be things like an ameloblastoma, which is a benign tumor. Other things would be like an odontogenic keratocyst, again, benign cystic lesions, but malignant would be an ameloblastic carcinoma like this X-ray here. These are pretty rare. And also you can get squamous carcinoma within the lining of a cyst, which is not uncommon. That's just a large ameloblastoma in a young person's maxilla. Treatment in some ways is pretty similar to what you would do for cancer. So partial maxillectomy for this man, and a maxilla made out of his fibula. Neck dissection, not for nodal harvest, but for microvascular anastomosis. So they come in various shapes and sizes. These are all um, patients that have a type of jaw cyst and tumor. That's a cementoma. That's an ossifying fibroma here. That's an odontogenic keratocyst. These are fancy things called adenomatoid odontogenic tumors, and that's two examples of ameloblastoma. So diagnosis, history, examination, look out for the jaw expansion, look out for mobile teeth, ask about numbness of the jaws because the sensory nerve runs through the jaw and supplies the lip. Look for mobility of teeth, get some decent imaging done, be it plain X-ray leading on to cross-sectional imaging, and get a histopathological diagnosis before you jump in to treat these. If these are simple isolated cysts, you can enucleate them. For things like odontogenic keratocysts, which have a higher preponderance for local recurrence, you enucleate them and then you use just use a big diamond burr or a round burr to drill out the bone in the surrounding area, which is called peripheral ostectomy. If it's a massive cyst where you want the cyst decompressed, and you've got a definite diagnosis of a benign tumor here or a cyst, then you can marsupialize this, decompress the cyst, and then go back and do a smaller operation. If it's a big tumor like this, although this is a benign ameloblastoma, treatment is still similar. I've just used some virtual surgical planning to design my cuts beyond the margins of the tumor, and that's a deep circumflex iliac artery-based vascularized hip free flap from this young lady's ipsilateral hip. Again, virtual surgical planning is useful both for cancer reconstruction and also non-cancer reconstruction. This is a young man with a benign tumor, ameloblastoma. It's useful to design where your cuts are. You use the scans to mark your cuts a centimeter beyond the extent of the tumor, and then you can then use the same technology to design your cutting guides for the reconstruction. So either from the fibula, the hip, or the scapula to design the construct for this patient. So that's a post-op, and these are custom-made titanium plates for an accurate fit. So the other thing, Rajiv, so that's just the mucosal lesions that you will commonly see, and some jaw cyst and tumors, which are very common. Chantal, I'm happy to take any questions here if needed, or shall I carry on to the next topic?
I think if we carry on, and just a reminder to everyone, if you've got questions, then do post them as we go along, and it helps me in terms of collating common themes.
Okay, sure. So I'll carry on. So the other thing Raji wanted me to cover was temporomandibular joint, which is the medical name for your jaw joints, made of the condylar head or the condyle of the mandible and the glenoid fossa, which is the lateral floor of the skull base. Between the two bits of bone, there is a piece of gristle cartilage which forms the disc, which is bilaminar in shape. The vascularity is usually at the periphery. The central aspect of the disc does not have vascularity and actually doesn't even have any nerve ending. So if the patient's getting pain, discomfort, inflammation, it's mainly the joint capsule, the synovium, which is getting inflamed, fluid in the joint capsule, and the nerve ending sitting at the periphery of the disc. So in simple terms, if patient has a temporomandibular joint dysfunction, it can either be purely the insides of the joint, as in the bony bits, hence arthrogenic, could be the insides of the joint within the arthrogenic, so the bone, the capsule, the ligaments, and the disc. Could be myogenic, so the patient might have overfunction. There might be heavy clenchers, bruxism, clenching, can then put strain on a normal joint, and hence they might get pain, discomfort from it, which is called myogenic. And the third one is the neurogenic, so neuralgias around the jaw joint. It's not uncommon for patients with temporomandibular joint symptoms or presenting as temporomandibular joint symptoms might have problems with the middle ear or mastoid, and also it's not uncommon for you to see in your otology clinics patients presenting with ear discomfort or sounds in the ear which is coming from the temporomandibular joint and not the ear itself. So we've just touched on that. So from a management and assessment point of view, it's important to know that it's not uncommon for the general population to have some kind of joint noise, which could be suggestive of a possible disc problem, and depends on the spectrum of things. If you've got a completely asymptomatic joint, no problems with function, and you get an occasional click, you don't need to chase these patients and treat them. Just reassurance is all that you need. Some of these will have neck, head, preauricular stiffness, pain, discomfort, and even a smaller percentage will have true limitation of function, as into restriction in mouth opening, problems chewing, recurrent joint dislocations, or open or closed locks. So what I mean by that is you have to ask the history of whether you managed to dislocate yourself, can't close, or have you found that opening mouth is difficult. But then patients might say that initially difficult, and then they wiggle it and they can then open it, or they can open it and they get stuck. So open and can't close is an open lock, can't open is a closed lock. These would then, if there's an obvious history of these, then you need to investigate them with further imaging. So clinical assessment is really important. History is important. Previous history of trauma, previous joint operations, previous middle ear or ear infection, or odd history where the patient complains that the diet is changing, and you can see an open bite between the teeth, and the face looks a bit asymmetrical. Look out for oddities. Some CT is useful for bony features. MRI would be MRI is the gold standard for intra-articular disc problems. So a couple of pictures here of chondromas. This is a chondrosarcoma of sticking out from the head of the condyle here. And this is an MRI axial. So you need these, that's the disc in place. You need static and dynamic images of the condyle, and ideally done by radiologists and reviewed by radiologists who are used to looking at temporomandibular joints. And then treatment. If you're a non-TMJ surgeon, even within maxillofacial or ENT, and if you don't do these routinely, it's best to have a friend who looks after your patients and refer it to them. Initial management is absolutely fine. Most of the time, counseling, reassurance, diet advice to stay on a soft diet, physiotherapy. I do Botox for functional jaw joint problems, especially the myogenic ones where you've got masseteric hypertrophy, regular joint clenching, and that helps with defunctioning or taking the load out of a slightly compromised TMJ. People who have parafunctional habits, clenching, grinding, nail biting, they do find CBT useful. Surgical management can be either arthroscopic, as endoscope assisted diagnosis, endoscope assisted disc repositioning, or open joint procedures. And as I said, for non-TMJ surgeons, assess, rule out other problems, get basic investigations done, and then refer to a specialist who deals with it. So that's a quick flyby with regards to TMJ. We are pretty much halfway or a bit further from that. Next aspect is cervicofacial infections, quite commonly managed by both ENT and maxillofacial. It's very common for you to see retropharyngeal, lateral pharyngeal, Ludwig's angina, mediastinitis, quinsy, and also not uncommon where you might have patients who present what looks like what is a cervicofacial infection, but from a dental cause. So just a reminder from our anatomy days, there are several layers of fascia with sheath different important structures in the neck, and there is no true space. These are all potential spaces. If fluid fills up, if pus fills up, then a space is created. Without that, all the tissues are stuck together neatly. Quite common for people presenting with grotty teeth, causing big neck swellings, very common emergencies for maxillofacial with neck abscesses. It's quite useful to understand how the infection spreads. It can go, if that is the lower teeth, can go from that area, as I said earlier. So infection starts from within the tooth or tooth fracture, and then caries, and then this infection spreads either outside. In that case, this will be spreading to the cheek. You'll see somebody who looks like a chipmunk, half of their face swollen. When you start getting trismus, it's when the muscle space, the masseter and medial pterygoid are getting inflamed, or an obvious abscess that's tracking into the masticator space. This can also go towards the floor of mouth, causing a sublingual space infection, submandibular space infection, and once it's in the neck, then it can spread very rapidly. So Ludwig's angina, by definition, I'm sure most of you must have seen, board-like floor, tense, patient can't speak very clearly, can't swallow, limitation in mouth opening, sublingual space, submandibular space on both sides involved. And that's a young lad in theater about to have an incision and drainage. That's the scan. You can see the ET tube in place, and there is not much around here apart from these locules of pus and fat stranding. So dental source is likely, can have an abscess, frank abscess, or just might be marked inflammation. They do rapidly progress, so hopefully don't wait for it to develop into an abscess, but take them to theater, early intubation, and I've done tracheostomies for these patients as well, and then appropriate management with incision and drainage. Sometimes even if you don't get frank pus, it's worth draining it so you can decrease, decompress, and put drains in. Parapharyngeal abscess, again, parapharyngeal space, dental infection, tonsillitis, parotitis can also do that, mastocytitis, spread from surrounding surfaces. Can have coexisting supraglottitis, pain, dysphagia, trismus, stridor, and dysphonia. Risk to carotid and retropharyngeal spaces. Again, drainage could be either, most of them will need a transcervical plus minus a transoral route. Depends on where it is spreading from. Again, some scans of parapharyngeal collections, retropharyngeal collection, and posterior neck collection as well. So simple things, have a very common sense approach to this. Airway is paramount here. They might be systemically unwell, so breathing circulation. Think of the cause, investigate them appropriately, bloods, F&E if needed, imaging, antibiotics. Start off with a very broad spectrum, send tissue and pus samples from theater if you've drained them. It's good to send fluid pus and ask the microbiologist to do a gram stain as an early indicator of antibiotic swap if needed, and then closely monitor till they get better. Extensive neck infections, if you're keeping them intubated after drainage, then might need to go to ITU till you can get them extubated. So that's the dental infection part. This last bit is facial trauma. So unless any questions, Chantel, shall I carry on? This is the last part of the talk.
So we've got a few questions just in terms of the TMJ dysfunction. Yeah. A common question was asking when it's appropriate to refer to dentist versus OMFS.
Okay, so if it is if you've ruled out there is no otological cause for the discomfort, and this patient does not have any limitation in jaw mouth opening, this is something that the dentist can manage. Most of the time it's reassurance, telling them it's a very common problem. It's not uncommon for people to have some occasional clicky joints, but if they've got no pain, no discomfort, no limitation in mouth opening, you could discharge them or get the dentist to review them. If there is obvious limitation in mouth opening, there is obvious joint sounds, there is pain, there is locking, then a referral to an OMFS colleague would be appropriate, with or without imaging. So if you're sure and your unit has a good radiologist who looks after and does MRIs and reports MRIs for TMJ, then definitely get some imaging done. If there are obvious red flags, as in sudden onset pain, discomfort, rapidly growing lump in that area, or sudden change in their bite or occlusion, then definitely go for imaging with a CT plus minus MRI. These odd tumors affecting the jaw joint are not that common, but you won't miss anything if you have imaged them and then referred them on if there is nothing nasty there. So in summary, if they are asymptomatic, they are doing okay and they can be managed by the dentist, onto dentist, otherwise max fax.
Great, that's excellent. That's covered a few of the questions that we've had coming in on that topic. And then just going back to your slides on Ludwig's angina, we've had a couple of queries just in terms of the approach that you would use for incision and drainage.
Yep, okay, so let's take an example. So if we go back. So the problem is not just in the sublingual. So that sublingual space completely filled with inflammation, edema, and pus, if there is, submandibular and submental spaces. In this patient, you would need bilateral drainage. I would drain from both sides. I would stick a drain in the middle in the submental space. I'll have a good feel inside of the mouth, and if needed, I'll put intraoral drains on both sides as well. So don't stick 26 drains, but definitely look at, feel, and see where the potential areas are. If you've got good imaging, then put your drains towards where the obvious focal areas of collection or edema is. So bilateral submandibular, submental, and intraoral drains going towards the floor of mouth and towards the back, towards the masticator space. And usually there is an obvious cause, and if there is an obvious tooth which is causing it, or an nasty quinsy which is turned into this, then go towards the source of infection as well. If there is a obvious grotty tooth which has caused this, then get the source of infection out. So that tooth needs to be removed as well. Does that answer the question, Chantal?
Yeah, no, that's really helpful, thank you. And a quick question that should be more of a simple answer. Just simply, do the submandibular and sublingual space communicate?
Yes, so remember what I said earlier, these spaces do not exist. If you go into somebody's neck during a normal neck dissection, it's not a space where the submandibular gland sits. These pseudo spaces are created with fluid, pus, infection, inflammation. So it depends on the extent of the infection. If this is an isolated infection going from a tooth straight into the submandibular space, like so, then it does not mean that the pus has gone into the sublingual space. So if the floor of mouth is nice, soft, you can't see any obvious collection, it doesn't mean there is pus sitting above the mylohyoid line. If there is boggy swelling inferior to the mandible, lingual to the mandibular, then the submandibular space is inflamed and infected. So chase the space which has got infection. You don't need to don't stick drains into areas where the infection hasn't been or hasn't gone. And the last thing you want to do is put so many drains that you then start creating spaces for the pus to go.
That's really interesting, thank you.
So shall we go on to the last bit?
Yeah.
So facial trauma is very common. The most exciting ones are at the top of this list, as in panfacial, as in the whole of this face is smashed up. But the most common ones are the bottom of the list. So fractured lower jaw, fractured cheekbone are the most common in this country. Whereas if you were working in, say, Chicago, parts of India, South Africa, or maybe even Glasgow, where I did my SHO jobs, it depends on the extent, type of injury. You could get more significant multi-bone injuries in the face. Usually, usually the isolated injuries might be punch, interpersonal violence, or interpersonal sports, as I like to call it, falls, they usually end up breaking one jaw generally. More significant falls from heights, fall, or injuries during sporting injuries, high impact motor vehicle accident will cause polytrauma in the face. If that is the case, then you are expecting panfacial fractures. Also remember, if you've seen one fracture, look for another fracture, especially in the lower jaw. The lower jaw is like a boomerang, and if you get direct impact here, you will get a fracture on that aspect where the direct impact is, but also look for a counter coup and an indirect fracture on the other side. So again, with facial fractures, remember the ATLS principle, A, B, C, D, E, but from a facial fracture point of view, don't forget the eyes and don't forget the C-spine. The higher the injury on the face, it's correlated with lower C-spine fractures, and lower face or mandibular fractures can be associated with higher C-spine fractures. Do not forget about intracranial injuries. It's quite common, and especially if you are, especially the juniors on the forum here who are cross-covering for Max cross-covering for ENT, especially A&E doctors see them, send them into the scanner, just get a head CT scan and forget to cover the face. If the patient has clinical features of a facial injury and is going to have a head scan, please ask the radiologist to scan the face as well. And it's very common, sometimes that is missed, and then the patient needs further imaging. We've already covered this. History is really interesting. When, where, how, who did it? Mechanism of injury, point of contact in the face, loss of consciousness, retrograde and antegrade amnesia, alcohol. I don't know why I put a question mark. I should maybe just say period. Everybody, quite a lot, significant number of people have got alcohol on board. How did they get here? Is this a walking wounded? Is it an ambulance or your local ambulance service? And has police been informed? Especially the juniors in the forum here, make sure these things are documented, because if you have then moved on to different greener pastures, it might be a registrar or a consultant having to do a police report based on your complete excellent note keeping or incomplete, not so great note keeping. Imaging is useful. So if it's a straightforward mandible fracture, a panoramic dental X-ray or an OPG, and a posterior anterior view of the mandible, and I'll show you these pictures. So 2 X-rays, please. Just 1 X-ray is not useful. Fractured cheekbones, occipitomental, which is a slightly tilted face view, which I'll show again, is useful. But more and more people are getting CT scans, 3-dimensional imaging for facial injuries now. CTs are essential or extremely useful for things like orbital injuries, midfacial injuries, or panfacial injuries, not just for diagnosis, but for treatment planning. And you can get 3D reformats done. Either you could do it on your own PAC system by yourself if your trust allows it, or you can get your radiologist to do it. So mandible, most common bone broken in the face, or cheekbone, one of these two. The parts of the lower jaw, I'm sure like most of you know, between the canine teeth is called the symphysis. The area next to the here is called parasymphysis, as in adjacent to the symphysis. Body of the mandible, angle of the mandible here. Then further up is the ramus. The front pointy out bit to which the temporalis tendon attaches is called the coronoid process, and the part that forms the jaw joint is the condylar process. So again, all that bit of history, asking how the injury happened, quite a lot of times gives you clues as to where else the fracture might be. Single punch on the jaw, say for example on the left angle, look for a fracture on the contralateral parasymphysis. It's a common feature of patients having an ipsilateral angle fracture with a contralateral parasymphysis or a contralateral condylar fracture. Occasionally people or patients or individuals for unwitnessed falls or faints. If you're standing and suddenly fall down on your chin, then the impact is on the anterior aspect of the mandible, and all the force is then distributed towards the condyle. So you might see patients with a and midline fracture symphysis, and bilateral condylar fractures or jaw joint fractures. Historically, this was called the guardsman fracture, as in a guard being on duty for a very long time, collapses, lands on his chin, smashes the front of his jaw, and bilateral condyles. So the summary for this slide is, if you see one fracture, have a good look and check the rest of the jaw is okay. And trying to diagnose a fracture, especially for the jaw, on one X-ray, you will miss. So if the A&E SHO registrar is just selling you a fracture with one X-ray, ask them to do another X-ray for you. Again, the reason for not just the mechanism of injury, but also the muscle pull, the suprahyoid muscles pull the front of the jaw downwards, the masseter and pterygoid muscle, medial pterygoid, pull the mandible upwards in that direction, the coronoid pulls the mandible up, and the lateral pterygoid pulls the jaw forward. So multiple muscle pulleys, and a fracture depends on the direction in an AP plane or in a superior inferior plane, determines how the fragments move. So this would be a favorable fracture because the fracture runs from back to front. If things smash, even then the muscle pulls it, and that angle of fracture stops the mandible moving out of place. This would be an unfavorable fracture, and imagine having this on both sides. Somebody be sitting with the jaw hanging down, finding it difficult to keep the mouth closed, breathe, and swallow. Same principle is reflected here with the direction of the mandibular muscles pulling. So again, Chantal, open for answers here. So can everybody see, can anybody see a fracture on this, on the first one? So that's a panoramic X-ray or an OPG.
So there seems to be a fracture of the mandible.
Yep, which I'm pointing to.
Yeah.
Okay, so that's a parasymphysis fracture. And as I said to you last time, or in a few slides ago, single punch here. I've looked for this. Now I am going to scan this fracture, this X-ray, to see if there's anything else. So I suspect something here. I can't see anything on this X-ray.
Yeah, and we've got a question now of that left condyle.
Left condyle. So this is left. Yeah.
Yeah.
So, but what I was trying to point out here is that just looking at, if you were only given one X-ray, it's amazing how you can so easily miss that fracture. This is the same patient, but with a posterior anterior view of the jaw, you can see the fracture. So subtle signs, despite good X-ray, you can miss these fracture. If the bony fragments are overlapping, you might not see that fracture. So just a reminder is to always ask for 2 X-rays for these. Elderly patients do fall, have got a really pencil thin jaw, and not uncommon for them to break the jaw in 1, 2, 3, or 4 places. This is pretty difficult to manage conservatively. It's very difficult to put small plates and screws in them, and with their medical comorbidities. But in an ideal world, you can either splint them with their own dentures if they have it, if they haven't smashed it, or you can use a plate across it. And the way we do it is to minimize periosteal stripping for these fractures, because all the vascularity is coming from the periosteum. Their endosteal blood supply diminishes with time. So yes, fix these fractures, but be very careful about the vasculature to that area and the rest of these patients. Again, briefly touching on these condylar fractures. So an open fracture, something like this, you need to fix it quickly, as in I would say within the first 24, 48 hours. If you've got an isolated closed fracture of the condyle like this, so ignore this fracture here. If this patient came to A&E or to your clinic just with an isolated condylar fracture, check their bite, see what their occlusion looked like. And I suppose if this was the only fracture, potentially you could get away with it. Once the swelling settles down, once the muscle bruising settles down, they will get back to function. If despite all that, their bite is deranged, as in for a fracture like this, it's most likely they will be touching on these back teeth first because the vertical height is reduced. In that case, and if there's further shortening, they will need fixation. So, but these are fractures which can be brought back to clinic, and you don't need to admit them. And this is again just for the juniors in the group who end up cross-covering for maxillofacial. So condyle fractures can be displaced, non-displaced, dislocated, as in completely out of the joint, or especially in pediatric, can be intracapsular as well with hemarthrosis inside. Young children getting that kind of injury, they have to be, even if you're not fixing it or doing anything about it initially, they have to be monitored long term because they are at a risk of getting TM joint ankylosis. Cheekbone fractures are common. Again, could be a single punch, fall. It's sometimes subtle enough that if you see them face on, you might miss it. So therefore, have a look from underneath, or stand behind the patient, have a feel of their face, have a look at them. And I generally put my fingers in the infraorbital rim area, sweeping around to the zygoma, and you can then see a depression, which might be initially masked by soft tissue swelling in that area. Imaging for these patients is plain x-rays, or you can get a CT scan. If you're getting plain x-rays, it's good to train your eyes so you don't miss things. This is a good, the McGregor and Trepner lines. This was described in 1973, long time ago, but it's a good way of looking at x-rays. You start with the first line, supraorbital rim, frontal sinus, supraorbital rim, onto zygomatic process. Zygomatic arch, infraorbital rim, lateral nasal wall, nasal septum, infraorbital rim, and bang, there's a fracture there. Zygomatic buttress and zygomatic arch, there's a fracture there. And then you go further down, condyle, ramus, lateral wall of maxilla, there's a fracture there. And if you follow these lines, it's good that you will not miss fractures. This is called an occipitomental view or facial view. And again, A&E or other specialties, just get them to give you two x-rays, one at 30, one at 10. It just means my head is at 10 degrees, 30 degrees, so you can get a better perception of the fractures. Another way of looking, this is usually from an A&E textbook, where it looks like a snout of an elephant. And I don't know whether this x-ray projects very well, but if you use that elephant line, infraorbital fracture, zygomatic arch, and lateral wall of maxilla. So a zygoma fracture, which is twisted inwards from the cheek, from the zygomatic arch, and you will feel a step in the infraorbital rim. Most of these can be fixed by early intervention. You don't need to fix them within 2-3 days. You can do them within the first couple of weeks. And something like this can be fixed just by lifting the fracture, putting it back into place. If it's not stable, then we put some plates and screws to hold them in the right place. Interesting case, young chap who presented as such to any blunt trauma to his left side orbit, and then he blew his nose. You can see an obvious orbital or ocular dystopia, as in the level is different, and he had no obvious displaced bony injury, but that significant emphysema has pushed his globe down. Some books have described this as the black eyebrow sign on the plain X-ray or the CT. So I just thought that's so emphysemas. Most of these you don't need to treat them. Just make sure there's no orbital compartment syndrome, the eye pressure is not raised, and the vision is not affected, and it settles spontaneously. Very, very, very rarely you have to decompress these, but that will be extremely rare. That's the reason why if somebody's had a midfacial fracture or a cheekbone fracture, you advise them not to blow the nose for the first 3 or 4 weeks till things settle down. You might see patients with significant air emphysema and falling blunt or trauma to the face. And again, conservative management is all you need for these.
Mr. Jayaram, I'm just mindful of the time. If you are able to move to your final slides, that would be great, please.
Sure. Okay. So just a couple of emergency things. Again, orbital fractures in a young child or a teenager where the muscles are, where the bone is quite pliable. You get a trapdoor defect, the bone breaks, traps the infraorbital contents of the inferior rectus or the globe contents and traps back. And they will then get significant pain on looking up, can mimic head injury. They might be sick, might have vagal symptoms. And like you can see, this child is now trying to look up and he can't move his eye up. This is an emergency, needs to be treated within the first 24 hours at least. Otherwise, you get tissue necrosis and permanent risk of diplopia. Another emergency is retrobulbar hemorrhage, proptosis, tense globe, loss of visual acuity. Lateral canthotomy is the treatment of choice. Medical management isn't. Most people dealing with either A&E, ENT, or MaxFax, and ophthalmology should know how to do a lateral canthotomy and a canthalysis. And if you don't know, please phone a friend and don't dither, don't waste time. Tooth avulsion, that's just a screenshot you can take, dental trauma guide. If I get lost, this is what I look for. That gives you answer how to deal with the teeth. That's me done.
Well, thank you ever so much. That was really helpful, and it's remarkable how many topics we're able to cover in such a short space of time. I think we've only really got time for perhaps one question. So we've got a query asking what the indication is for emergency mandible or maxillary surgical reduction.
Okay, so as in all mandibular fractures, especially in the dentate segments, as in fracture going through the teeth area, which is an open fracture by definition, needs to be fixed within the first 24, 48 hours. Emergency management would be that it's an unstable mandible broken at two places, it's an airway risk, they can't close them out, there's massive bleeding, then you need to take them to theatre ASAP. For emergency for maxilla, most of the time, if it's significant bleeding from the nose, from the mouth, just putting 2 bite blocks and tamponading the maxilla against the skull base gets you out of jail. Once you've done that, put some nasal packing and speak to your anesthetist with regards to how do you manage the airway, intubating them, and if needed, tracheostomy if you're going to deal with his other injuries at the same time at a later date. If you are doing a panfacial fracture, then might be worthwhile just fixing the lower jaw, getting the airway sorted, waiting for the neurological conditions to settle down, and then going back and dealing with the complex mid-face fracture, just from a time point of view. So hope that answers that question.
Yeah, no, thank you ever so much and for your time today.
And I just want to say thank you very much to you and Raji for the invite, and all the best.
Thank you.
Bye-bye.